Critical care grab bag. So we're going to talk about maybe three things that I think that you'll find pretty important. Before we get into this chapter, though, I thought we should just basically remind ourselves what ARDS is, because some of these respiratory therapies exclude people with ARDS. You shouldn't use them with people with ARDS, and some you can. So basically, this is, I can't breathe really well. I'm having tachypnea. I may have some rales. The insult was pneumonia is filling up the alveoli. We have a toxic gas. Maybe you inhaled some chlorine. Maybe you're septic, and now in the septic process, all of these agents are out there that are destroying your tissues. So your lungs now become heavy and wet, hard to blow them open. So the compliance, which is the term they use for the ease of expansion, goes down, and the transfer of oxygen is abysmal. And yet on top of this, your pulmonary capillary wedge pressure is okay. So it's not a cardiac event at all. It is a process going into your chest that's gotten so bad that you're quite hypoxic, no matter how much oxygen you were giving. We take an x-ray, we see this white out in three fields. And there is a gradation. Some people are, you begin not so bad and you wind up bad. When we intubate somebody in the emergency department, they talk about, we do 250,000 intubations a year in the emergency department, and that what happens in the emergency department moves up to the ICU, and it will generally stay in terms of what you do with regard to settings. So we know from prior studies that lung protective ventilation, it even has the word protective in there, is safer for the lungs than not using lung protective ventilation, which means that we're talking about 8 mLs volume or less per kilogram of these patients is what they're going to get ventilated with. And there was a prior large study that said lung protective ventilation will give you a lot of good things happening if you use it. Now the question is, if you use it. The first paper there is a survey of 8 emergency departments, and they found that only 58% of the people got lung protective ventilation, when in fact it's believed that, well, if you think that this is the thing to do, then it should be 100% of the people get lung protective ventilation, unless you know about lung protective ventilation, but say, in this case, we're not going to use it because for this reason or that reason, whatever it is. Yes, they talk about things that lung protective ventilation will do. It will statistically significantly be associated with lower mortality, lower ARDS, and shorter length of stay. So it's kind of a big deal. Lower mortality, I think it would be interesting. So this is 4,000 patients, and they said, we're not doing so hot at all. So the next paper is about a quality assurance process where they looked at what their lung protective ventilation rate was in the emergency department, found that it was 23%, miserable, and they had this 8-month QI project to get them to use it. I have no idea what would take 8 months to get this done when you would say to the respiratory therapist, turn the knob up. Turn the knob up. That's all it would take, kind of thing, This is not like a big intellectual process here. It's called turn the knob up. But they did 8 months, and it went from 23% to 72%. And what they found is that when the patients went up to the floor, they continue with lung protective ventilation. So you were doing them a favor, and they did a lot better. They didn't get to 100%, but after 24 hours after admission, even they raised the number, lung protective ventilation percentage in the ICU to 83%. So you did a good thing. You got them started in the right pathway, and I don't know why this would be a hard thing to do. So I would ask you, are you using lung protective ventilation routinely? 8 mLs per kilogram or less? Anybody? Yes? I don't see any. Come on, we're all friends now. We're all friends. It's okay, I won't tell. The idea is you should say, well, I don't because, and I don't because. I'd be interested in the becauses regarding this. Next thing is about PEEP. So after you've intubated them, the first thing that happens is you're at 10 centimeters of water for PEEP pressure, because everybody knows that's going to help hold the alveoli open with this pressure, and you'll get better gas exchange if you PEEP them up. And we've been doing that for a long, long, long time. This is prior to the abstract 3, randomized trial of non-ARDS patients, particularly excluding ARDS, using a strategy of getting your PEEP down to 0, because there's at least one large trial has found lower mortality and other benefits with lower PEEP in intubated patients without ARDS. So that's going to be something where if you can distinguish between ARDS and not, that you would not be using 10 of PEEP anymore, and that you would just gradually turn it down till you would maintain 92% oxygen is what you'd like. You're going to decrease the PEEP and turn up the oxygen, inspired oxygen concentration to get your 92%. So this is like, we're really screwing up everything. The idea here is we're not necessarily using the lung protective ventilation enough, and we're still using the idea of PEEP is good. And these people are saying PEEP is good in ARDS, but it's not good in other situations. So that was the idea of lowering the PEEP. And this is a study of 980 people where they basically tried to lower their PEEP, and they were very successful. The ventilation-free days was the same. So this is one of those non-inferior studies where 0 PEEP is non-inferior to 10 centimeters of PEEP. So the next time somebody says, let's go to 10 centimeters of PEEP, you might want to bring out a couple of these to say, well, not so fast. Maybe things are changing here. We're learning a little bit more about what harms the lungs and what doesn't harm the lungs. The next paper talks about another thing that would be very unusual to do. So you've got a bad asthmatic. And they're talking about giving bad asthmatics non-invasive ventilation. Not just passively giving them oxygen on their face, but non-invasive ventilation, which would be like high flow nasal oxygen, 60 liters a minute is flooding them with oxygen, so it's pushing it down as well. BiPAP, CPAP, you would never do CPAP, BiPAP in an asthma patient because they say, well, the problem with asthma is getting the air out. And we're trying to get the air out. And now you're going to put them on something, you're going to push the air in. You're doing just the opposite of what needs to be done. You need to put a vacuum on their face here, wall suction, help unload the lungs. So we got an issue here because this paper is number 4, 50,000 cases of asthma exacerbations admitted to the ICU. And the relationship here is the use of non-invasive ventilation, high flow oxygen or BiPAP, CPAP, occurred in 25% of the patients, which is kind of surprising because generally it's like, well, you probably ought to not do that. But since these are intubated patients, or these are sick patients going to ICU who are not intubated, 25% of them got non-invasive ventilation. When they got non-invasive ventilation, 88% of them did not have to be intubated. So there was a connect here, because in those people who did not get non-invasive ventilation, only 21% of patients who were ultimately mechanically ventilated did not receive non-invasive ventilation. Only 21% of patients who were ultimately mechanically ventilated received non-invasive ventilation. So Giving non-invasive ventilation decreased substantially your risk of being intubated, and not giving non-invasive inhalation increased your chances of being intubated. So this bad thing physiologically really turns out to be a good thing. So high flow O2 on a bad asthmatic, they don't usually have problems with oxygenation. I mean, their blood gases, their O2 is fine usually. So the idea here is they don't necessarily need that oxygen, but it's pushing it down and flooding and making it so that intubation can be avoided. So that was a good thing to do. In my day, that was kind of like, oh, you wouldn't do that. I mean, because the problem is getting air out, and why would you be pushing air in? The odds of intubation were 0.36, which means your odds of intubation went way down. Mortality went way down. Now, not being intubated or intubated is kind of like, well, I don't want to be intubated. But mortality associated with this, now these are associations. This is not a randomized double-blind trial kind of thing. But I think it's pretty impressive, the numbers that we're generating here. Next section is, okay, so the idea here is lung protective ventilation. You kind of do it. If you do it, it will stay done up in the ICU. It is protective, lung protective ventilation. Low PEEP now, try to get that thing from 10 down to 0. You know, you can just have the respiratory therapist say, here, we'll make this the setting, and if it doesn't work, we'll talk about it kind of thing, rather than start at 10 centimeters of PEEP and, you know, give a lot of volume and more than lung protective ventilation. Okay, what about pressors? Can you run them peripherally? You know, don't do that, don't do. You're going to get it's going to infiltrate here, and next thing you know, the skin's going to die. You're going to have a big slough here from doing that, and so don't do it. But you're saying, well, this patient's really sick, and I got to get this thing in, and I'm having some trouble doing this or that, and I got to get it in. So this is a look at peripherally inserted lines for pressors. Most of them were above the antecubital, where you can put it here, you get an ultrasound, and run one of the longer catheters up there. But we generally believe that's bad and dangerous. Paper 5 is a look at a 2-year experience at one hospital. 127 patients had peripheral pressors run in, and 5 patients got into trouble. 5 out of 127. But of those 5, only one of them had an extravasation, and that extravasation did not lead to tissue necrosis or anything like that. So, and the other 4, they said unspecified problems, but nothing serious. So 5 out of 127, only 1 had an extravasation, no skin break as a result. So that really kind of says, well, it doesn't sound as bad, but that was only one study. What about, give me more. Abstract 6 is a 9-study review of peripherally inserted IVs for pressors, 1,800 patients, and out of those 1,800 patients, 122 of them had some kind of a problem. How many of them were serious? 5% of them were non-minor, 5 of them. So it's 5 out of 1,835. 5 out of 1,835 is 0.27%, less than 1%, a quarter of 1%. Of the 122 patients that had problems, 117 were minor. That leaving 5 patients again. This is a study with 1,900 patients, had 5 patients in trouble. The other study had 127 patients, and they had 5 people in trouble, but none of them had any kind of skin slough out of 9 studies, and the other hospital's own study, that's 10 studies. So it wasn't really a problem. Most complications were infiltration or erythema requiring no treatment. No necrosis occurred in that 9-study analysis. Next is push-dose pressors. Push-dose pressors is going to get the job done. You know, it's going to raise the blood pressure kind of quickly kind of thing. It may be an expedient thing to do. It's not maybe as nice as your infusion, but what about push-dose pressures? This first paper, chart review, push versus no push. Push versus no push. 1,300 patients in the ICU, and push dose was associated with more short-term hemodynamic instability, because you can envision that. Push it, goes up, push it, goes up. So that's one thing, but it was associated with a higher mortality. Maybe push dose patients were sicker, and if Ken were here, he'd say, we need a randomized double-blind trial to make that assertion. But mortality is kind of a bad complication, and so it suggests that push dose pressors ought maybe be avoided. But are there any other studies that say that? That study that I'm talking about had 1,300 patients in it. What about push dose pressors in the pre-hospital setting? Well, where you may have to do it, you don't have much choice in terms of what you're going to do. Still found higher mortality with push dose pressors in the pre-hospital setting. That's number 8. 4,374 hypotensive patients were included in this study. And the 24-hour survival, 66% in push dose pressors, 82% in match controls not getting push dose, but getting their pressors in the traditional way. So 66% versus 82%, big numbers when you're talking about survival. Bottom line, pressors can be given peripherally, and push dose pressors should be avoided. There's not a lot of evidence that this is a good thing to do, they say. And this is kind of like some of the first papers are really looking at the consequence of push dose pressors. What's new in critical care IV fluids? So there was this SMART trial of 16,000 people, and we're still trying to decide in 2022, saline versus Ringer's lactate. 2022, we're trying to decide, 16,000 people, a lot of work trying to find out the answer. Well, the SMART trial basically said there's a 1% benefit with giving balanced fluids, like Ringer's lactate or some of the fluids that they commercially make. 1% benefit out of 16,000 people trial. But what was that benefit, 1% benefit? It was a composite. A composite is a target made of various components. And if you hit the target at any spot, and you still have basically, that was the 1% benefit that you avoided. So what was the target? Death, that's bad. Also on the target was dialysis. That's bad, but not as bad as death. And the third thing was a bump in your creatinine. Well, if you hit the target, I'd hope that you hit the target that says bump in your creatinine. This is an example where a target is very unequal in terms of the significance of it. But if you got any of those three, death, dialysis, or creatinine bumps, that was considered one of the things that would occur to you more often if you were not on balanced fluids. When you say more often, how often? 1% number needed to treat. 100 people need to be treated with saline to get one person having hit the target being death or dialysis or creatinine bump. Number needed to treat is 100. With the problem with this study, 16,000 people, this got to be the answer, 1%. Roughly 1 liter of crystalloids was given in this trial. It was blinded, and the total amount of fluids roughly 1 liter. How can you possibly make a statement about one fluid over another when you gave it 1 liter of it, for crying out loud? So you got to do better. Basic study, which is next, 75 Brazilian ICUs, 11,000 patients over 3 years, which is better. Double blind, which the other one wasn't double blind, careful selection of patients, that's better than the other one too. And they gave 4 liters of fluid, was the average in that one. So now we're talking about some decent amount of fluid, where in fact the fluid in fact may be able to influence the outcome. Basics found no difference in any important outcome independent of, so the fluids didn't matter at all. No difference whatsoever. So you pick what you like, that's it. Mortality at 90 days was kind of used as the marker. The problem with mortality at 90 days is that's a really very definitive endpoint. But maybe the fluids made this part better of their, maybe it made this part better. And making maybe this part better, it's kind of like the links of a chain. If I could make this part better, and that part better, and that part better, and that part, maybe the outcome would be better. So, but it didn't work in this case. It's interesting that the numbers that you get when look at mortality for these ICU patients who are, needing resuscitation, it's always in the mid-20s. 25% died at 90 days in the balanced fluid group, and 27.2% in the saline group. No significant difference was seen for renal injuries. The only group that made a difference was head injury patients. Only the head injury subgroup saw a significant mortality difference favoring normal saline, 31% versus 21%. Now this is not a, this is just a review of 11,000 cases. It's a record review here. So you can't say for sure that that's the case, because when you think of hypertonic saline for head injuries to shrink the brain, well, how hypertonic is normal saline? I mean, it's got a 155 sodium. Maybe it's a little bit hypertonic, but probably not much. But in any case, head injury patients would be the one exception. So if you don't have to worry about anything, you would run normal saline for everybody. And that's what they run in kids now. Before they used to run, let's give quarter normal and half normal, and we never really knew what fluid to give the kids. It was like a secret that only the pediatricians knew who got quarter normal and it turns out it's normal saline is what's used now. Normal saline, and normal saline. Doesn't matter how old, how the percentage dehydration, none of that matters. It's normal saline. What about fast versus slow in the resuscitation of people getting 4 liters in these studies? The basic study had another component where they looked at fast versus slow. One was 1 liter an hour. The other was a third of a liter an hour. 1 liter an hour versus a third of a liter. Do you think that made any difference? Nothing makes any difference, it seems, with this. It made no difference. No important difference in 90-day survival or any other important outcome. And that was 5,000 people getting the rapid, 5,000 people getting the slow. Huge numbers. Total amount of fluid infused during this phase was about a liter, which is a small amount. So I thought that was kind of one of the weaker parts of the study. Well, look at the mortality, 27%. Next is, there are some people who say, despite the fact that these studies don't show a difference, these one guys came up with the idea that, well, we still think that the balanced electrolyte fluids are going to be better. And that's paper number 11. The SMART trial basically said, we think, we've changed and worked out these statistics and done this survey so that, in fact, we think there's a 5% advantage for balanced fluids in the SMART trial. The SMART trial really didn't find it balanced, but they made some and came up with that number. And on top of that, the New England Journal came out with an article. They have a new section called New NEJM evidence. Yes. And what they basically do is they go do a deep dive. You have to pay more money. You have to get to subscribe to this. This deep dive coming up with the answer. And they also came up with, there was no difference in the 16,000 patients and 30,000 patients, no difference. But when they did Bayesian analysis, which Ken will tell us about, they made they made the statement that there was a 90% chance that balanced fluids decreased mortality of patients, which was really a tough one. It makes no difference in kids. Here's a study of 3,000 kids, no difference in kids in terms of their resuscitation. Yes, it's called New England Journal of Medicine. The first issue was on the saline versus balanced electrolyte solution. Found no statistical benefit for mortality. But they then say, the authors then claim a Bayesian analysis suggests probability that balanced fluids reduce mortality. The probability is 90% that they reduce mortality. It doesn't tell you the number that they reduce mortality. It says there's a 90% chance that they reduce mortality. Despite the fact that all of these studies, these huge studies, say that's not the case. So it's roughly 34,000 patients were assessed in this analysis. So what is the answer here? It doesn't seem to matter what fluid you use at all. I was always in favor of balanced electrolyte fluid because it was like replacing what was in your bloodstream. You had four milliequivalents of potassium. You had 140 milliequivalents of sodium. You had 100 milliequivalents of chloride. You didn't have this normal saline's got 155 milliequivalents of chloride, hyperchloremic acidosis, 155 of sodium. The number's supposed to be 140. It's like, why would you give that wacky fluid when you had this other one that's nice, this had a little calcium in it, had a little potassium, a little this, a little that. The percentages were more consistent with what was in the bloodstream, and made sense to me. But despite the fact that it made sense to me, all of these papers basically say it doesn't matter, except for head trauma in the one study. And Ken's going to tell us why Bayesian analysis allowed them to come up with the belief that there's a 90% chance that mortality is decreased with electrolyte solution. Did I kind of make it unfair? Are you prepared to answer that question?
It's all about the bays, no trouble.